Good morning. Happy Friday, and welcome to our MOQC Biannual meeting here at St. John's Inn, one of our favorite places to have our meetings. I'm so pleased that we have such a wide variety of people attending today, our Faith and Culture panel. All of our MOQC physicians, our sponsors are here. Very important, our Patient and Caregiver Quality Oncology Council, who we call for short POQC because it rhymes with MOQC, and for other reasons too, and other guests. We have a couple people who are survivors here today, so just welcome everybody. I'm so delighted to see the room full. We moved into a bigger space. It's hard to imagine looking out that we ever managed to fit in that smaller space. I'm hoping everybody's more comfortable today. So we're going to get started. I hope everybody's had their coffee and some breakfast and have your name tags and your agenda in front of you. Of course, I'd like to thank our team. Our mission is up here. As you know, our mission is to make Michigan the best state in the country for cancer care. Today's theme is culture, faith, and difficult conversations, and as always, we try to deliver patient and family-centered care while supporting our practices, of course. So I'd like to acknowledge our sponsor, Blue Cross Blue Shield of Michigan. They don't tell us what to do, but they support us in what we do. We'd like to thank all of the hospices who are here today and have been supporting us in improving care at the end of life and people with life-limiting cancer diagnoses. Tips for Health is an initiative from University of Michigan, and Dr. Hawley will be talking about that today. The Michigan Department of Health and Human Services are present today. Debbie Webster will be talking. POQC I already mentioned, and as well as everybody else who's here. So we provide continuing medical education credits, and I am a consultant for PBGH, which is a nonprofit entity. They hold the CMS grant, Collecting Patient-Reported Outcomes, which you'll hear more about in a bit. And Michael Smith, who's one of the breakout session leaders, is a consultant for Wolters Kluwer. There are no other disclosures. These are our objectives. We hope to, at the end of this, you'll be able to analyze your experience and improve practice, to integrate relevant content, to provide cost-effective healthcare that does not compromise quality of care, and to integrate relevant content to ensure multi-specialty, multidisciplinary coordination of care. The competencies are listed here. And brand new, we are now able to provide continuing education credits for pharmacists. So social workers, nurses, pharmacists, and physicians can all get continuing education credits, and there'll be more information about that later in the program. Okay, now we're downloading some data. The way we're going to show this is by practice. You should know your practice number. The most important thing, though, is to look at the 25th percentile, 75th percentile, the overall variation, and then for 4 of our measures, the targets that we're aiming for. And then I'll show you, these are the measures that the VBR have included in the past, and then we have some new measures that we'll cover in just a second. So by practice, I'm going to go through, this is pain addressed appropriately by the second office visit and during the most recent visits. So you can see the median right here. I love that I have 2 screens, and it's quite high, over 90%. The 75th percentile, we're looking at 99%, 100%. The 25th percentile still continues to be quite low. So if your practice is there, although we're retiring this measure, this is something you might want to focus on. I'm not going to go over what the measure defines because I've done that at every meeting, but of course I'm available, and all of us in the MOQC team are available to explain that measure. All right, signed patient consent for chemotherapy. We were in the 40s and 50s when we picked this measure, and we now see that the median is quite high, over 90%. Quite a few of our practices are at 100%. And the 25th percentile practices, this is something you'll want to work on. Although we're, again, retiring this measure and not collecting it anymore, those practices that have a lower proportion of their patients in whom we found signed informed consent, this is still a very important process for patients. So it's not that it's not important, it's just that we really topped out in terms of the median. The next measure continues to be an important measure to us. We have a grant from the state, and tobacco cessation, as you can see, counseling administered or patient referred in the past year continues to vary. So quite a few of our practices among their smokers are referring their smokers for counseling in the last year. You don't need to do this every visit, but we're seeing a lot of practices at 100%. And then we also, our median is close to 90, but we have quite a few practices that are under 70%. Emily Mackler will be coming up and talking about resources we have available. We're still onboarding practices. This is one of our VBR measures. So value-based reimbursement, your practices will get an uplift if you meet this target. It's actually at the regional level. Our target is 75%. So we are doing well in a lot of our practices, but there are practices that have a ways to go. Still very important measure, and it's a VBR measure for this year also. So this remains an important measure. Actually, all of them are, but it remains a key measure in terms of uplift, in terms of added dollars to your practice in the region. Okay, this measure is looking at the use of, and this is actually an overuse measure where we're using NK1 receptor antagonists, which are expensive, or olanzapine, which has side effects, in people who don't need it. So these are regimens that are very unlikely to cause nausea or moderately likely with the first cycle. That doesn't mean you can't add it with the second, or if somebody had chemo years ago and had a bad experience. This is chemo-naive patients getting these drugs that are not guideline concordant. This is one of our new quality measures Dr. Mackler will be going over. And this is a VBR measure for this year going forward. The target is 30%, and you can see that a lot of our practices are below that target, so good for them, but we have a fair number of practices where they're using this over our target. And we'd actually like to see it get lower and lower. So each year we lower the targets. We want our goals to be a stretch, right? We want to have man's grasp exceed his reach, to quote Robert Browning as an English major, sorry. This measure looks at infertility risk before chemotherapy in patients of childbearing age, reproductive age, so men are included in this measure. And we have a lot of practices at 100%. The median is quite low. And the 25th percentile, we're seeing a lot of practices where there's no counseling in patients of reproductive age. So we have a lot of practices where their population are older patients, but these are in their patients of reproductive age. Now we're retiring this measure, not because it's not important, but because so many practices have an older population. We have a load of resources on our website, decision tree, and practices you can refer to in your area, in your zip code. Sam Busterian of our team put this together. Please go on the website and take a look at this. Complete family history documented for patients with invasive colorectal cancer. We're not doing very well on this. You'll see in a minute how we're modifying this measure. So I'm just going to leave it at that. We're retiring that and replacing it. Colonoscopy within 6 months of, basically within a year of finishing chemo, because we're seeing people on chemotherapy. We've done very well in improving this. The 25th percentile or below practices, you'll want to work on this. You partner basically with a gastroenterologist or with the surgeons to make sure this is happening. We were very low on this measure when we picked it, and we've really improved performance, so we're retiring this measure in our measure set. Now, pain addressed appropriately at the end of life, we were very low when we picked it. It was a VBR. It no longer will be, but we've done very well in improving this measure. Hospice enrollment. This is really the key area that we're working on in the collaborative right now. Our other areas, of course, are very important. Dr. Mackler will go over those, but this is really the focus. So thank you to all the hospice folks who are here today. Can we have a show of hands? Who's here from a hospice? Woohoo, I'm so excited. Thank you very much for being here and for raising your hand. So hospice enrollment, we are below the COPE, which is the national benchmark in green. if you aren't colorblind, red-green colorblind, and we make up a big proportion of COPE. MOQC contributes a large proportion of data to COPE, so if we were to take MOQC out, I bet COPE would be even higher. Does that make sense? The national average would be higher if you sucked out the MOQC practices. So 75th percentile, doing well. The median is lower than the national average. The 25th percentile, we'd like to see especially work on this, and we're providing a lot of resources. You'll hear more about that in a minute. Our target for the VBR is 50%. So there's some practices well above that, but we want to help, a rising tide raises all ships. So that's our effort right now. What we'd like to see is people on hospice for longer, and in fact, we've changed this measure to 7 days. A lot of us would like to raise this to 30 days. As oncologists, the ideal time, of course, is 6 months, and we're working on that as well, but we're just going to move from 3 to 7 days. You want to be lower on this. So the practices that are at 0% means of their patients on hospice, 0% were on for 3 days or fewer. So this is one of those wrap-up measures where you have to have patients on hospice first. The practices that are at the median or worse, we'd like to help improve hospice enrollment for longer, because that's when families and patients truly benefit. Now, this measure includes hospice enrollment or discussion. So this is to help us give doctors and other clinicians more practice at getting comfortable with these discussions. We have resources like Vital Talk, and a lot of people have enrolled in Vital Talk training. So I'm really pleased that we're able to offer that. We're paying for the licenses for you to enroll and get more comfortable with these difficult conversations. They even have an app for free that can help you if you mess up and you say something wrong. And I've been using this and I've learned some really great scripts, and that's really what this is. It's skills and scripts, so I'd encourage you to use the app, and then you can also enroll in the training. This is a VBR measure for this year, and our target is 65%, so a lot of practices are above that and quite a few below that. Chemotherapy administered within the last 2 weeks of life, you want to be lower at this. And so you see some variation here. Obviously, we're not going to get to 0, right? None of the measures do we aim for perfection. There are some things where we aim for perfection, like patients falling out of hospital windows. That's a measure in England where it's a never event. A retained instrument, that's a never event. I think dose reductions in the first cycle of chemotherapy is a never event. But most of our measures, hospice isn't right for everybody. Some people, you don't know that they're going to die of an unexpected adverse event in the last 2 weeks of life when you give chemotherapy. So we're not actually aiming for perfection in any of these measures. So we never pick 100% or 0%, but you'll notice there is some variation here. Okay, so these are some measures that we're maintaining as we go into our next round. Those of you who do abstraction will know this. Oral chemotherapy, we're actually looking at assessing medication adherence, not just documenting it or assessing it. We're going to continue with tobacco cessation counseling, as I showed you. We're going to keep the lower is better. Don't give antiemetics for high emetogenic regimens to people with lower, moderate emetogenic regimen, pain addressed appropriately at the end of life, hospice enrollment or documented discussion. This is actually a revised measure because it used to include palliative care referral, but that can happen at any point in the disease trajectory, so we separated that out, which I'm really pleased about, because hospice is really for people facing life-limiting illness. Palliative care you can do in patients getting their first cycle of chemotherapy. Chemotherapy in the last 2 weeks of life we're keeping, and serum tumor marker surveillance in patients with early stage breast cancer. I didn't show you the data because the data we're getting from COPE, there's a problem with the denominator, so it looks like 100% of practices are ordering this in all of their patients, which is not true. So we're working with the vendor who manages our data on that. Next time you see the data, it should be right. Here are some changes that we're making. So these are added or created. MOQC creates a lot of measures for COPE. They're called test measures. We try them out, and then COPE actually adopts them, which is kind of cool. So we're actually looking at monitoring oral chemotherapy following the start of therapy. And then we looked at overuse of antiemetics. We're now actually going to look at underuse of antiemetics in those patients getting high emetogenic risk chemotherapy. We're looking at hospice enrollment, and we're keeping that, but we're looking at 7 days of death. We think that's better than 3. Again, ultimately, we're going to go to 30, which we should be able to do because we know the date they enrolled and we know the date that they died. So, but we're not yet going to make that one of our measures. We want people to ease into their skills. Patients with prostate cancer receiving androgen deprivation therapy who get a bone mineral density test within a year of starting. I know for the abstractors this is a very difficult measure. We don't expect that our measures committee will keep this. We're going to be meeting soon, and we don't expect keeping that, just so you know, but we will have data for a couple rounds. Bone-modifying agents administered for breast cancer has been a measure all along. We added multiple myeloma just to increase the patient numbers who are eligible. These are bisphosphonates and denosumab for our patient advocates here in the room and patients. Complete family history for all patients with invasive cancer. So I showed you colorectal cancer, but everybody with cancer should have a complete family history, because patients, we're missing a lot of people, many people, about 90% of people with cancer. We have a reason to collect their family history. A complete family history is first and second degree family members, all cancers. Eventually we're going to find the genetic component to all cancers and the age at which they were affected. So we'll be working with our clinical champions to work with their colleagues who aren't here today to help disseminate this measure and explain why it's important. If you don't know the age at which they were affected, you write unknown age. That counts as a complete family history. And then we're looking at growth factor administered for people who are getting chemo with non-curative intent. The measure right now in our measure platform is just in non-small cell lung cancer, but we want measures that apply to all patients. It increases the number of patients in whom that measure applies. Does that make sense to everybody? So we're trying to get more cross-cutting measures to increase our number of patients in whom we can measure that. If you're a small practice and you have 4 patients who qualify for that measure, or 2 every 6 months, we can't really give you data on your performance. It's just not meaningful. So now look at all your patients, you increase your subject number, your confidence intervals are more meaningful. You can act on that data. All right, and then these are measures we're removing. I'm not going to go through all of them. I gave you the reasons why as we went through them. Okay, so here's some changes in the value-based reimbursement measures. I'm also going to explain how this works a little bit, and this slide is really helpful for those of you, especially administrators and clinicians, and frankly, everybody here. So we pick our measures, just to remind you, and I know some people weren't here at the last meeting, we pick measures that are meaningful at the patient and population level. If they're not meaningful, why measure them, right? This is like the moral era of measurement that we're aiming for. And guess what? Our patient and caregiver council, they can veto any of our measures. They have the veto power. If it's not meaningful to them, it's not meaningful. The clinicians have to have an interest in this too. So our measures committee, if they're not interested in that measure and working on it, it doesn't make it. It addresses the value equation. Value doesn't have anything to do with money. It has to do with what you're getting in terms of patient care. So yes, it has to do with dollars, but what are you getting for that? So value for money, and does this matter in terms of, are we getting what we're paying for? If the current performance is not too high, if it's not topped out, it's a candidate for value-based reimbursement. And if it's not too low, sometimes if performance is so low on something, there's probably something wrong with the measure. It means that there's no agreement among people about how to deliver care. There has to be some variation. If everybody's at the same level, unless we differ very greatly from the national average, we're not actually going to count this as a value-based reimbursement measure. And it has to be novel and interesting, not just to us, but to our sponsor, to patients. It has to be something that gets you excited. So not just interesting, but kind of cool. It's kind of the freshness criterion. Okay, so to be eligible for value-based reimbursement, the region, we measure this at the region. MOQC is divided into 6 regions. Practices got to pick which region they wanted to be in, and the region itself has to meet the target for 3 of the 4 measures. And then at the practice and physician level, one physician of the practice, doesn't have to be the same clinical champion. In fact, we like to see variation because then we get more buy-in, attends one biannual meeting, and somebody from the practice has to come to both regional meetings. It's a 12-hour commitment plus travel. And multiple people can come. So if you've been coming to every meeting and you've got enough people in your practice, please come. Now, there are exceptions for practices. We never want you to have to close your practice or bring in a locum to be able to come to the meeting. Okay, so patients first, right? The second thing I want you to know is that the payment is based on your retrospective care, but it's prospective payment. So if you met those VBR measures that I just showed you, that we went over, it's going to apply to your E&M codes for this coming year. So now our VBR measures are changing, but they apply to 2021. So it's always worth working on the future measures, even when we retire them, because it's a little complicated. Louise knows a lot more about this, and so do Mark and Jackie. And we are also trying to come up with some cool VBR measures that work at the practice level, like, did our clinical champions engage? Oh, I'm on stop? Are you kidding me? Okay, I'm wrapping up. I wasn't looking at you guys. You gotta jump up and down, I guess, or whistle. So I'm almost done, actually really almost done. Really quickly, to be paid starting March 2020, those VBR measures that I showed you before, those are the targets that people had to meet, plus the attendance or participation. And we're gonna increase and add some variation to those so-called participation requirements, like everybody in the practice getting to see the measures and their performance. Isn't that better than just the champions? And then to be paid for 2021, those are the measures I showed you in the targets. So this is just a great summary slide. These will all be on the website. It's great to take pictures, but they will be available early next week or maybe the week after. We've got a lot going on. Okay, and then my last slide is to introduce our MOQC update. Hey, I did great.
Hello, my name is Kirsten Mowry. My pronouns are she and her, and this is my 1-year anniversary as a member of MOQC. I want to say thank you to the BEST Planning Committee. We held our first retreat yesterday, and so I'd like to thank Mike and Diane and Kelly for being amazing people to work with, and I'd like to thank everyone who attended. We did 2 sessions. In the morning, using the World Cafe model, we identified areas of meaning and attention for all MOQC members. Our intention in holding the retreat was to take all of our experiences as patients and caregivers and harness them to benefit all future patients and caregivers, as well as current ones. Some of the highlights from the morning World Cafe were we didn't want any more silos between physicians or within an institution. We really preferred the idea of tunnels that enabled communication, education, and care. Another idea that came up was the idea of navigators or guides, someone who had a vision of the entire process and could guide the whole person through their care, directing them as to when to ask, whom to ask, and what to ask, depending on where they were on their care journey. And finally, the view of the whole person in terms of education, in terms of care, and in terms of the relationships that surround them. After that, we had a presentation about patient and family advisory councils and how they can best help us to direct the information we garnered. After lunch in the afternoon, we took some time to touch into the shared well of grief that we all have. There is no way you can work with cancer without grief. And we took time to recognize our need to keep the grief moving so it doesn't congeal and harden our hearts. and acknowledging what we all carry so that we can restore our humanity, our dignity, and our vitality. The next step for POQC is to turn the World Cafe information into specific, measurable, and relevant requests for MOQC and the state of Michigan. Thank you.
Hello, everybody. Good morning. I'd like to start off with an interesting fact I just learned the other day. So at Disney World, in case you're wondering, all the American flags are missing either a star or a stripe, so that during national tragedies, they don't have to lower them on Main Street. So just a fact to start your day off. So just a quick update from the steering committee. I'm going to start off with the dissemination of practice data to practices and the organizational leadership. Of course, as you know, the goal, as Jennifer already went through, is really to truly increase and support the practices and the dissemination of data to the practices so we can continue to work toward quality improvement. As such, MOQC will be providing a ready-made slide deck to the physician champion for presentation at either their staff meetings or business meetings or by whatever means that particular office or organization disseminates information to their physician leadership and staff. The physicians at this meeting will be asked to sign in, that thereby demonstrating that they've attended and they've participated and they've witnessed and seen the slide deck. And CME credits will be also made available for those physicians by participating. So with those CME credits, usually there's a short questions or questionnaire to demonstrate that they've acquired some knowledge from that, like we do typically for any other CME related activity. In addition, practices that do the presentation will be eligible potentially for additional uplifts going forward, as Jennifer mentioned a little bit earlier. And also there will be additional support potentially offered for the physician champions that are participating with this as well. So what MOQC really wants to do with this and what the goal certainly is to increase that participation, increase the activity that we're doing with our physicians, make sure that all the great work that we are working on as physician champions and administrators that are participating in MOQC really gets disseminated to our staff and our practices and get them more engaged. And so this is that first step toward really helping us to help them with that engagement. So our next item of business really is looking at additional speakers for future meetings. As always, this is a meeting for us, by us, and our participation is incredibly important in making these meetings valuable to us. So if anybody has any great ideas for speakers for our upcoming meeting, which will be in June of this year, we'd love to hear it. Just a reminder, too, that the Measures meeting is coming up in June. Now, we do have some members that have been participating in our steering committee, and they will be rotating off. So, of course, we are looking for volunteers, and on each one of your tables, you will see a volunteer form for participation in the steering committee and as well as other opportunities for engagement and participating in MOQC. So if you take a quick look at those, if you want to volunteer yourself or you want to volunteer somebody else, this is a great opportunity to do so. Lastly, we are going to recognize those people who have truly offered great support and service to the steering committee, but are rotating off. So I would ask you please to come up. We have a little gift to thank you for the participation. So we'll start with Dr. Ernie Balcavera, and he's here today, I know, I've seen him, yep. And then Ed Smith, Isabel Lee, Cindy Fenimore, Bridget Vandenbush and Mitch Berger. I believe that neither are here today. But Beth Holtz, I think, if you're here, if you could please come up and receive the gifts for them, and then Pat Morley. So once again, we would like to thank all of you for the service that you provided to MOQC. We really have appreciated it, and thanks again.
Right. Hello. In 2019, MDHHS received a one-year grant to look at increasing the number of referrals of women with ovarian cancer to gynecologic oncologists. The CDC really thinks that this is important because there are significant survival advantages to women who are seen by gynecologic oncologists for treatment of their ovarian cancer based on the specific training that they receive. In addition to collaborating with MOQC, we also are working with the Michigan Ovarian Cancer Alliance to disseminate some resources that we'll be developing. So you can see on the map here the burden of ovarian cancer in Michigan. This is 2012 to 2016 data. The gray areas on the map indicate we had less than 20 cases in that county in that time period. And then you can see burden differences between the light yellow, which is low incidence rates, and the dark brown, which is higher incidence rates. And as we work on these referrals, we're going to do a few things. We have an MDHHS navigator who's going to provide patient navigation for these women. So if they are in an area where we don't have a lot of gynecologic oncologists, they can call MDHHS. We're going to assist them with insurance, transportation, lodging needs, those types of things. But we also can facilitate the referrals to the gynecologic oncologists. MOQC is actually developing a couple of patient education resources. One's going to be a checklist. What are all of the things that I should do if I think I might have ovarian cancer? And it's going to start with, who you should see first. And if you have ovarian cancer, it's going to look at things like genetic counseling and those types of things. MOQC is also developing a podcast, which I can't wait for. I think that's going to be really cool. We're also looking at doing some provider education pieces. So MOQC is working with gynecologic oncologists. We're also looking at doing provider education pieces. And MOQC will be going out and doing some training with general surgeons, primary care providers, and gynecologists. Yeah, that word. So anyways, the second project that we're collaborating with MOQC on is a program called Cancer Thriving and Surviving. And I was recently talking to a young breast cancer survivor about her experiences. And one of the things she said to me is when I got my survivorship care plan, I felt dumped by my care team. And I take that very, very seriously. She said, I really felt like I was told, go have a nice life, see you in 6 months, but I really didn't know how to do that. And I think this program like Cancer Thriving and Surviving can kind of step in the space there. It really talks about helping people develop a self-management perspective at looking at their cancers. And so it helps them look at issues like nutrition, physical activity. It helps them set their own goals in achieving different types of things. It's a 6-week class, 2.5 hours. It's all evidence-based. It's all been tested. So see your MOQC staff. This is something that they're working on developing right now. The third project that we're collaborating with MOQC on is a brand new grant, and it's a program for breast cancer in young women. And this program focuses on women who received a breast cancer diagnosis under the age of 45. And the goal of this is to address the unique needs of the women that have these early age cancers. We're not only looking at early stage, but we're looking at metastatic cancers. The other thing CDC's asked us to do with this grant is to address the needs of caregivers. So we're going to have several priority populations as we move forward with this. We're going to be looking specifically at the needs of underserved women, And our overall goal is going to be to really look at resources and how to develop those and get those, to the women so they understand that they're there, so that we increase mortality and quality of life. I also have a map on this one, which shows the incidence rates. Again, gray means that there was less than 20 counties, and the dark burgundy would mean that there is a higher incidence. One of the things that we found in the data when we were looking at and applying for this grant is that while the incidence rates of breast cancer in young women is higher in white women, we have a higher mortality in black women. That's often true in breast cancer. And there's factors that go into that, that can be seen in our data. We've got the higher incidence of triple negative breast cancer, which of course has a higher mortality rate. Metastatic breast cancer is often diagnosed later in black women. But the one thing that really concerned us when we were looking at the data is that Michigan has a significantly higher mortality rate than the national average in this black women, which is what I've highlighted on the slides. So one of the things we really want to do is to figure out, if nothing else, how we can get our black mortality rates, at least down to something that would be closer to the national mortality rate. You can see when we do the same comparison for white women, in Michigan, we actually have a little bit lower of a mortality rate. So there's definitely something there for us to work on here in Michigan. This kind of ends my presentation. If you're interested in any of the projects that we talked about, see one of your MOQC staff persons, see me. I'll be here all day. I've given you my email address. We're actively looking for partners on any of these projects, and I'd be happy to talk to you more about any of them.
Thank you. My name is Sarah Hawley, and I'm here from the University of Michigan Rogel Cancer Center, and good morning. I'm really happy to be able to come a year from when we were first visiting with you all last year to kind of kick this project off. This project, Development of Sustainable Cancer Control Research Capacity in Rural Michigan, was a project that we launched with funding from the National Cancer Institute, which was given to comprehensive cancer centers to really start to begin relationships and partnership building with states that had significant rural populations and practices. And so we were really fortunate to be able to do that with MOQC, as well as with our colleagues at Karmanos Cancer Institute. So we partnered with Dr. Lauren Hamill from Karmanos, us, and MOQC to kind of do the work that many of you have participated with us over the last year. So I just wanted to give a little update on what we've been up to and what our next steps are going forward. So what did we do in a year? We had a little bit of funding. I'm sure you all are familiar with sort of funding from the federal government. Supplements tend to be very small, but we were able to do a lot with that money, and we still have a little bit to go with the rest of the project. First, we updated and enhanced our Tips for Health platform, which Dr. Griggs mentioned. This is a texting SMS platform which was developed by the National Cancer Institute and then brought over to Michigan, where we updated it and kind of fancied it up a little bit, and then we gave it to a lot of the practices here. We're also deploying it with our employees at Michigan Medicine and throughout other channels throughout the state. So we've had nearly 3,000 users so far. It promotes smoking cessation, diet, and exercise. So we're still working on that. We've also added a colorectal cancer screening platform to that. We interviewed 11 of you, and thank you very much, those of you who met with us, talked with us over the phone, and participated in those interviews. We have reviewed and summarized the themes, and I'll present a little bit of that work shortly. We conducted a motivational interviewing session in mid-Michigan, and thank you to those of you who helped set that up with us. Dr. Ken Resnikow from the School of Public Health went and kind of began some training around how to promote cancer prevention and control counseling. We had good feedback, and we really hope to do that again. We deployed a rural smoking survey in collaboration with the Cowell Family Cancer Center with our Munson colleagues. We just got that data in, so we're excited to look at that, and we can share some of that back as well. What were some of the challenges we identified through those interviews? None of this will be surprising to anyone in this room, whether your practice is in a rural or urban location, but distance and lack of transportation services comes up again and again. How can we get better transportation services out to communities to bring patients and their families in? Financial burden of cancer on patients and families. This is clearly an issue in rural counties, but also nationally we hear a lot about financial toxicity and what can we do to kind of help patients with the burden of the cost of cancer. Access to genetic testing and counseling was something that we heard from you a lot about. How can we link patients to better link them to testing services and counseling services? How can practices get resources to give to patients and families who need that information? Shortage of oncology and primary care. We were particularly interested in that transition when patients leave the oncology practice and go back to survivorship. And how does that work in rural counties in Michigan? And we heard it works well, except for that there's a shortage of primary care. So we need to think about what are some alternative ways and how we can help to improve that. Shortage of support staff, things like navigators, social workers, financial counselors, things that comprehensive cancer centers tend to be able to offer their patients, but we need to figure out ways to get those resources out in rural communities. We learned some lessons. First and foremost, there is a need for cancer prevention and control initiatives in our state. A texting program such as Tips for Health does hold some promise. However, we learned that we need to think about this issue of data plans. A lot of people in Michigan, most people have a phone. Not everybody has a data plan that can support an intensive texting program. So we need to think about that. We also learned that we need to think about improving mood and reducing anxiety. So that's an area that we may put some resources toward in terms of another program that we will develop. Our next steps are to focus on trying to improve access to genetic testing and counseling and to do some better linkages with all of you, with us at the Rogel Cancer Center and Karmanos, as well as the state of Michigan. We're seeking funding to do that. We're working with Munson on the rural version of the Tips for Health that we will develop based on the feedback we get from the survey that we're looking at right now, and our ongoing collaboration with Karmanos and with hopefully the Michigan Department of Health and Human Services we've been meeting with to talk about ways we can deploy Tips for Health and how we can partner, again, with all of you and with our state. And so with that, I thank the team. I thank Dr. Griggs, Louise, and Shayna, and all of you who really participated with us in the interviews, and I hope to be back a year from now or sooner with some more initiatives. Thanks very much.
Okay, the last one in this beginning session, so just so you're not worried about more transitions, I'm going to summarize for you guys where we stand with many of our quality projects. We don't always get a chance to go through the different phases we might be at with all of these, and although I'll be giving you a very brief summary this morning, I want you to know that our entire team is available throughout the day. We'd love to talk to you more about any of these. If you're interested in taking part in any, please let me know. Or if you feel like you haven't really received data updates regarding current involvement, let us know that as well. So we have several quality-based projects that are currently running or in development. You can see on this slide that we have several that are active and we're still enrolling practices. Those are related to tobacco cessation, oral oncolytics, hospice enrollment, patient-reported outcomes, and chemotherapy-induced nausea and vomiting. As you may recall from Jennifer's discussion earlier, many of these quality projects match what our VBR and measures are that we're currently monitoring. Then we have several that are currently in development. We're looking at advanced imaging and serum tumor marker surveillance. We have in development a project related to oncology and primary care. And we are also in the stages of rolling out a pilot related to fatigue management. So tobacco cessation to start. This has been our longest running QI project and we think is still incredibly important for our patients across the state. There are still multiple opportunities for practices to take part. If you saw that your outcomes related to this measurement are not quite where you'd like them to be, we'd love to work with you and help you set up workflows within your practices to get closer to your goal. We have several a lot of information on our website that can be utilized, and for practices who are looking to improve in this measure, we still have maintenance of certification credits that are available if you take part in this. Our oral oncolytics project is probably our second longest running quality initiative. As you might recall, we've gone through several different phases with this project. I was able to present to those of you who are here at our last biannual meeting in June a summary of our most recent data related to this project. That is available on our website from the June 2019 biannual slides, so please feel free to take a look at that. That data primarily summarizes for you what we learned from our MOQC patient-reported outcome tool that we utilize in our oral oncolytic patients. And we had data that we received from practices who took part from over 600 patients. And we really found that information to be incredibly rich and helpful in helping us develop next steps to support this patient population. In addition, one of the questions I've heard from practices who have been engaged in this with us has been, how can we have clinicians provide this level of care? What billing opportunities exist for the care management that's necessary for this? We're creating a summary document for you. There are a couple different care management billing opportunities for nurses or pharmacists who are providing follow-up for this patient population that we'll share with you and put on our website. So that'll be included in this meeting update in the next couple weeks. As Jennifer mentioned, our very large focus in quality has been related to hospice enrollment. It's been a priority for us at our regional meetings. And the practices, all of you have worked intensively with us in developing useful resources to move forward and help support practices across the state. The majority of these resources are now available on our website. We also have available the opportunity for you to take part in Vital Talk for physicians. And so if you have any interest in this or want to talk more about it today, please see Jennifer, Louise, or Kelly. We've also very recently formed an advisory council to help support us in moving this initiative forward. And maintenance of certification credits are also available for this, for practices who are taking part in looking at how they can move the metric related to hospice enrollment. I'm not going to spend a lot of time on patient-reported outcomes because we'll have a presentation by those who are taking part in this initiative after lunch. I want to talk briefly about chemotherapy-induced nausea and vomiting. This is a fairly new measure for us and is also a VBR measure. Some background, there are both over and underutilization metrics, quality metrics for the use of antiemetics with IV chemotherapy regimens. We have been focusing thus far on the overutilization measure as our VBR measure. So as a reminder, Jennifer reviewed this when we looked at outcomes, but the indication for upfront use of neurokinin-1 receptor antagonist and olanzapine is for high emetic risk chemotherapy regimens. We see that there's overutilization in that they're prescribed in low or moderate risk regimens. So part of our initiative, our last biannual meeting, we provided education and resources related to this measure. Those slides are still available on our website, so if you're interested in getting a summary of the current guidelines and where this measure comes from, that is all summarized. We also have been supporting practices in assessing their own data. So we've been looking at what your MOQC measures currently are. We've also surveyed you the last year at 2 different time points to see what you currently have available in your pre-printed chemotherapy orders to help provide recommendations for changes where applicable to help you meet this guideline measure. So the results to date, you can see that MOQC's performance in the top chart is related to, is the purple bar, and you can also see that for this measure, being in the lower percentage is better. So we want to see less use in what's considered inappropriate indications. And we, although previously were fairly stable with overall COPI performance, At our last measurement point in the first round of 2019, we saw that we did drop below our target, which was 30%, so that's great. We still have several practices who are over this measure, and so we're working with you and seeing how we can help support you to get under that goal. We've also to share with you data related to the pre-populated antiemetic order survey. We have resurveyed practices right before this meeting to see if you've had the opportunity to begin working on your order sets. And approximately 50% of the practices who responded are either have already changed their order sets or are currently working on it. So I think that's great movement in just a one-year time period. I really applaud all of you for being able to accomplish that. Our next steps for this project are to analyze the next 2 rounds of data. We will send out just one more survey to see where you are in those pre-populated orders. And then we're also, for the work that you've done on this, you'll be able to receive maintenance of certification credits next year. The next project I want to talk about, now we're beginning the in-development projects. So advanced imaging and serum tumor markers. What we're looking at is the aspect related to pre-authorization burden to practices and physicians related to this. Currently, there's a peer-to-peer review process for different images. We are looking with Blue Cross about the opportunity for gold carding for certain practices who have shown that they fall within criteria for prescribing of these things. We're working with nominating a practice and its physicians to bypass the peer-to-peer review process based on performance, and are currently exploring this opportunity with Blue Cross Blue Shield. So more information on this one is to come. The next model that's under development is the primary care oncology model, or what we've called PCOM. Some background on this. There's a plethora of information in the literature that indicates that there are lapses in communication between oncology and primary care, that there may be opportunities for improvement in this area. We know that both affect the other. So cancer and its treatment affect comorbidities, and comorbidities have been shown to affect cancer outcomes. We have decided to do a pilot within MOQC, which is utilizing primary care pharmacists to conduct comprehensive medication reviews, or CMRs, on patients receiving cancer treatment that have at least one of the following comorbidities: diabetes, hypertension, heart failure, depression, or anxiety. And this is the data that we have on the pilot to date. So we had a list of 96 patients who fell within our criteria for enrollment. Of those, we had CMRs completed on 55 of those patients. Several of them we were unable to reach despite multiple phone attempts. 6 of those patients refused to have the comprehensive medication review completed, and you can see some are still in the works as far as being called. The majority of these patients, in fact, almost all of them, had updates made to their medication profiles. Probably doesn't surprise you, but often we see that the medication profile lists that are in the medical record are not always up to date. So one intervention that the pharmacist did at the time of CMR was updated the medication list. In addition, of these patients that were called, 1 in 5 of them, so about 18%, were referred for ongoing chronic disease management with the PharmD. So these are patients who are undergoing active cancer treatment, and their hypertension or diabetes or their underlying chronic condition was not being well controlled, to the point that they scheduled follow-up visits to get their medications titrated in order to improve their chronic disease state management. Also, 22% were referred for physician follow-up because of things that were identified on the phone call. So one patient, complete chance, of course, but at the time of the phone call, it was identified that the patient was experiencing a new arrhythmia. That patient was referred to their physician for immediate follow-up. There were other patients whose medications needed to be modified for their treatment. So we saw that 22% were referred for follow-up. And then there were 66 instances in these 55 patients where patient education was provided related to their medication, their underlying disease, and/or their lifestyle based on questions that the patient had at the time of call. And 22 total medication-related problems were identified, and you can see the categories in which they fell in. The majority were related to medication adherence issues, effectiveness of current therapies, and then safety of their medication profile. We really found this data to be striking in that we found that the patients who were called, there was a significant amount of impact that the pharmacist made on just this one call of reviewing their medication profiles and the patient's symptoms. We're looking at how to expand this pilot to other sites. If you are interested at all in this, please let us know. We're looking at how we can work with other practices related to this model. And then finally, the last one that we currently have under development is related to fatigue management. In 2 areas of work that MOQC has worked within the state of Michigan, one related to the safety of IV therapy, which you might recall Chris Fries summarized that project at our last meeting, and then also related to our oral chemotherapy project. Patients have identified fatigue as the most common symptom they've had related to their therapy, as well as the most bothersome. Really, what's been published in the literature is the most effective way to help support patients with cancer-related fatigue is for them to increase their physical activity. And when we've polled our patients and our providers, we've identified that that isn't always known and/or isn't always communicated to patients. So we are initiating a pilot that uses a patient-facing software that assesses patient fatigue level and helps support the practices in providing education and encouragement related to physical activity. We're piloting this in one site currently to see how feasible this is in current practice and how well received it is by patients and if it's effective in helping with their fatigue. In addition to that, we've provided and created educational materials plus this software program. And so we'll be able to share more of those results, I hope, at the next meeting. But if you're interested in this, please also let us know that. I'll be here down here if you guys have questions about our initiatives at all or throughout the day, as I said. Thank you.